Hello, my name is Babette Langeneckert, Senior Data Coordinator of Education at Missouri Cancer Registry and Research Center. Today we'll be talking about case finding for cancer reporting. The slides for this presentation were created by Lucinda Ham, Senior Health Program Specialist. The Missouri Cancer Registry and Research Center is housed on the campus of the University of Missouri in Columbia, Missouri. The Missouri Cancer Registry and Research Center is supported in part by a cooperative agreement between the Centers for Disease Control and Prevention and the Missouri Department of Health and Senior Services, and a surveillance contract between DHSS and the University of Missouri. Missouri is a research state for SEER. Our learning objectives for determining reportability will be case finding techniques, reportable list for case finding, cases that must be reported, cases not required to be reported, and ambiguous terms. What is case finding? In order to report a case, you have to be able to find it first. Case finding is a system for locating every patient who is diagnosed or treated with a reportable cancer diagnosis at your facility. Registries keep a tracking system or tickler file so that the status of case finding can be ascertained at any time. The link to the SEER case finding list is on the Missouri Cancer Registry's website. The web address is on the slide. Click on Cancer Reporting on the Missouri Cancer Registry website and then click on Cancer Reporting Hospital. There you will find the link to the SEER case finding list. Where is the case finding list found? The case finding list can be found on the NIH SEER website. The link is on the slide. Each year the list of codes is updated. Click on the current case finding list if you are abstracting 2022 cases. Older lists can be found on the SEER website below the current list. This is a sample of what the SEER case finding list looks like. It is based on the ICD-10 CM codes. It is several pages, so be sure to review the entire list. How is the ICD-10 CM list used? The ICD-10 CM code list is used to run a medical record disease index from your electronic medical record system, and your ID department may need to assist you, or you can request a disease index from the HIM department in Excel format. Use the range of reportable diagnoses on the case finding list for generating the report. Save the report or export to Excel format if possible. Compare the list of patients to those that are already in the registry. Watch for multiple primary cases. Copy the Excel file to create a working tickler list for case abstracting. Determine the frequency of running an updated disease index based on patient volume. This is the preferred format for the medical record disease index. Excel allows you to sort the cases alphabetically to eliminate repeat visits and capture multiple primaries. Other case finding sources. Retrieve copies of path reports from the lab, such as autopsy, bone marrow, cytology reports, and histology reports. Never rely solely on the pathology department to provide reportable cases. Use a list of patient appointments from the cancer center, such as radiation and chemotherapy infusion schedules. Search the surgery logs and surgery schedules, and search treatment summaries. And for imaging-only cases, search CAT scans, PET scans, and nuclear medicine. And you can search admission and discharge lists. The electronic tickler. Most electronic medical record systems can be programmed to create an electronic tickler file using the ICD-10 CM codes. The cancer cases can be placed in a work queue like those used by other health information management functions. Now we'll look at cases that must be reported. First are the analytic cases. These are patients whose initial diagnosis was made at your facility and/or any part of the first course of treatment was delivered or prescribed at your facility. And these are class of case 00, 10, 11, 12, 13, 14, 20, 21, and 22. Next are the non-analytic cases, and these are patients diagnosed elsewhere who had all first course of treatment elsewhere, but were seen at your facility for diagnosis of recurrent disease or for treatment of relapsed progressive disease. And these are class of case 32, 35, 37, and 38. And for these, you record all available information regarding the original diagnosis and treatment. Now let's talk about case eligibility. These are cases that must be reported. Both inpatient and outpatient cases are required. Malignancies with a behavior code of 2 in situ or 3 malignant are reportable, and those histologies in the hematopoietic database Appendix D are reportable unless otherwise noted. Benign primary intracranial and central nervous system tumors became reportable January 1st, 2004. The applicable list of benign and malignant intracranial and central nervous system tumors is included on this slide. Case eligibility continued. Cases that must be reported. Squamous intraepithelial neoplasia, grade 3, 8077/2 of the anus, AIN3, vulva, VEN3, vagina, VEIN3 are reportable, except when it occurs in the cervix or skin. Malignant tumors of the skin, such as adnexal carcinoma, melanoma, lymphoma, sarcoma, and Merkel cell carcinoma, must be reported. Any carcinoma arising in a hemorrhoid is reportable, since hemorrhoids arise in the mucosa rather than the skin. Pilocytic juvenile astrocytoma will continue to be collected even though the behavior code changed to a /1. And as of January 1st, 2021, all GIST tumors are reportable. Case eligibility continued. More cases that must be reported. Thymomas with behavior code of /3. Do not report benign thymomas. Carcinoid tumors of the appendix must be coded to histology 8240/3, effective 2015. Lobular carcinoma in situ of the breast is reportable. Mature teratoma of the testes in adults is malignant and reportable. Low-grade appendiceal mucinous neoplasm, LAM, and high-grade appendiceal mucinous neoplasm, HAM, are now reportable, effective January 1st, 2022. Now we'll look at some cases that are not required to be reported. Skin cancer with histologies listed on the slide, and these include the basal cell carcinomas and the squamous cell carcinomas of the skin. Consultation visits to confirm a diagnosis, classic case 30. Transient care for patients who receive treatment to avoid interruption of therapy started elsewhere, classic case 31. Path consultative reading of slides from outside facilities, classic case 43. Hospice or home health patients, patients with a history of cancer but no diagnosis or treatment at your facility, classic case 33. Patients with adenocarcinoma in situ and carcinoma in situ of the cervix, and also cervical interepithelial neoplasia and prostate interepithelial neoplasia, class of case 40, 41, 42, 49, or 99, and precancerous conditions or benign tumors other than central nervous system sites. Ambiguous terms are used to assist in determining reportability. Reportable cases are usually based on unequivocal statements made by medical practitioners that the patient has a reportable diagnosis. However, physicians sometimes use vague or ambiguous terms to describe a tumor when its behavior is uncertain. In instances where the pathology or cytology findings cannot definitively confirm a cancer diagnosis, or when imaging studies show inconclusive results, physicians may state the diagnosis in an ambiguous term. Ambiguous terms that are diagnostic for reportability are in the first column on the slide. Some of these are compatible with, consistent with, malignant appearing, most likely, suspected, or suspicious. Ambiguous terms that are not diagnostic are in the second column on the slide. Some of these are cannot be ruled out, possible, questionable, suggest, or worrisome. The ambiguous term must always include a reference to the reportable diagnosis being described, such as favors carcinoma or suspicious for malignancy. For example, suspected and suspicious or most likely constitute a diagnosis, but possible or worrisome does not. Now let's review some more examples of ambiguous terms. And of course, there are always exceptions to the rule. If a cytology is reported only using an ambiguous term, such as suspicious, do not interpret it as a diagnosis of cancer. Abstract the case only if a positive biopsy or a physician's clinical impression of cancer supports the cytology findings. Example number 1. A discharge summary and CAT scan results report CT of the chest compatible with carcinoma of the left lung. Although there may be no further workup or treatment, the case is radiographically diagnosed and is reportable. Example number 2. The only documentation says likely carcinoma. Synonyms of ambiguous terms do not constitute diagnosis. Because it does not say most likely, it is not reportable. Once again, terms that are not diagnostic for reportability include the following: cannot be ruled out, equivocal, possible, potentially malignant, questionable, rule out, suggest, or worrisome. In conclusion, Look up the ICD-10-CM list of reportable cases. Obtain a report from your electronic medical record system using the format shown previously. Review cases on the list by reviewing the medical record and determine reportability by searching for reportable terms. Remove non-reportable cases from your suspense or tickler list. Begin abstracting by using your own abstracting software or MCR's Web Plus program. And remember, MCR no longer accepts paper abstracts. If you have any questions, you can call MCR's helpline at 1-800-392-2829. Resources used for this presentation are MCR's online Fundamentals of Abstracting workshop, Missouri Cancer Registry staff, the MCR Abstract Code Manual, and the SEER case finding list. Thank you.